Good morning, everyone, and thank you for joining the Governor's Office of Health, Innovation, and Transformation Resources webinar today. Today we'll be talking about the connection between health and housing. I'm Jen McGowan, and I work with the GOHIT team. In just a moment, I'll turn over the presentation to Michael Gelder, the Executive Director of the Governor's Office of Health, Innovation, and Transformation. Before we begin, I will briefly go over some housekeeping items. The webinar today is planned for 1 hour, with presentations expected to last 45 to 50 minutes, and the remaining time for questions and answers. You will be placed in listen-only mode for the entirety of the webinar, and we'll be taking questions in writing through the questions section of your GoToMeeting application. You can feel free to type questions at any point, but we won't be answering them until the end of the presentation. We will repeat each question for the benefit of all participants, and if we don't get to your question in time, we will follow up via email after. Finally, I'd like to inform all participants that this session is being recorded, and you will receive a follow-up email later today with links to access the recording. The presentation will also be posted to the GOHIT website at www.healthcarereform.illinois.gov. So let's get started. I'll turn this over to Michael to begin today's presentation.
Well, thank you very much, Jennifer. I'd like to thank all of you for joining us for this Health Innovation Transformation Resources webinar. I am Michael Gelder, the Director, as Jennifer said. And today we will be discussing the connection between health and housing, highlighting the work of the statewide housing coordinators, who are Lori Baker, Juanita Irizarry, and Brady Harden. We also have Sam Mortka with us today from the Illinois Housing Development Authority, who's been a key part of organizing and coordinating the efforts between the Governor's Office and the Illinois Housing Development Authority. Before we begin the presentation, I would like to give a brief update on the recent activities of our office. The Office of Health Innovation and Transformation was created in January by Governor Quinn to help implement the Alliance for Health Innovation Plan. The Alliance for Health was a 6-month planning effort that brought together a wide variety of stakeholders to discuss specific innovations intended to accomplish the triple aim of the Federal Centers for Medicare and Medicaid Services. That aim is improving the health of the population, improving the health care delivery system, and lowering costs to assure that health care is affordable for the people of our country. The Alliance for Health Steering Committee continues to bring these stakeholders together to discuss the implementation of the plan. Work groups have also been established through the steering committee, and I will discuss those in a minute. I would like people to know that the state has submitted a letter of intent this week to apply for additional funding through the state innovation model to continue the work of the Alliance for Health. This funding will allow us to test specific innovations that meet the triple aim. The second round of funding, out of which we hope to receive up to $25 million a year for 4 years for a total of $100 million. This is a very significant amount of funding so that we can continue the effort that we started during the research of 2013 and actually implement those innovations intended to accomplish that triple aim. This week, we also submitted the 1115 waiver application to federal CMS. This application was one of the recommendations of the Alliance for Health and has been many months in the process. While we've been developing this application, we've received more than 600 comments from the public and incorporated many of those into the final document that we submitted. And the work groups that are now being established and were announced earlier this week at a meeting of the steering committee will allow us to pursue and put the details together that many of those people who commented on the waiver were asking. We will have work groups specifically focusing on 5 areas: delivery system reform, services and supports, public health integration, workforce, data and technology. These work groups will, 4 of the work groups will all begin meeting this month and will continue their work for the rest of the calendar year, and will continue as we negotiate the actual terms and conditions of the waiver with federal CMS. So these work groups will be our way of communicating with and helping engage the stakeholders of the state in the process to determine how we'll actually restructure our state's healthcare delivery system, our long-term services and supports, creating a 21st century workforce, and assuring that the public health system is integrated in with the healthcare delivery system in a more efficient and effective way. This process will be open and participatory and allow policymakers and stakeholders to advise the state on how to best implement the Alliance for Health and Section 1115 waiver innovations. So if you are interested, we would welcome your participation if you haven't already enrolled in one of the work groups. And you can enroll by submitting an email message at gov.gohit at Illinois, spelled out, .gov. And if you do this by the close of business Monday, June 9th, we'll be sure to include you in the notices about the forthcoming work group kickoff meetings. And if you're interested in more information about our application for the continued funding from the Centers for Medicare and Medicaid Innovations, or for more information about the work groups in general, please visit healthcarereform.illinois.gov, as Jen McGowan said earlier. And there are tabs there that contain all of this information in a lot more detail. So now let's turn to the purpose of today's webinar, and I will turn the presentation over to Lori Baker, one of our statewide housing coordinators. Lori?
Good morning. Thank you, Michael. I would like to begin starting out to talk a little bit about housing intersects with the Alliance for Health Innovation Plan. And if we look at housing, and in particular affordable housing plus services, housing figures highly in 3 of the 5 objectives of the Alliance Innovation Plan. The 3 objectives that housing is most important to are ensuring supports and services for people with specific needs, enhancing public health and addressing the social determinants of health, expanding the state's leadership role, and promoting improvement. Beginning with ensuring services and supports for people with specific needs. The specific needs that we are referencing are people that are frail and aging, developmentally and intellectually disabled, persons with physical disabilities, persons with a serious mental illness, people that are justice involved, people experiencing homelessness, folks involved with the child welfare system, and people living with HIV and AIDS. No one can manage and improve their lives if they don't have access to decent, safe, affordable housing. Supportive housing is an evidence-based practice underneath the Substance Abuse and Mental Health Administration, and at its simplest term, supportive housing is affordable housing plus the support services you need in order to live independently in your community. Underneath the next objective, enhancing public health and addressing social determinants of health, there are multiple studies and organizations that have recognized that housing is health care. The National Health Care for the Homeless Council recently produced a study that showed that 60% of an individual's overall health is determined by access to safe and affordable housing, education, public safety, transportation, healthy foods, social supports, and adequate income. Safe and affordable housing rises to the top of the list of almost every study. If you look at the 100,000 Homes campaign, which is a campaign that is a national campaign to house the most chronically homeless and vulnerable individuals on the streets of America who are at risk of death imminently in the next year unless they are housed, you can see that housing is essential to maintaining good health. The Department of Housing and Urban Development, or HUD, says that housing is a platform for improving the quality of life for many areas of your life. for family well-being, so for folks involved in the child welfare system, overcoming nutritional challenges, which we know is a part of good health, economic security, obtaining self-sufficiency, improving your education. It's a platform for people that are formerly incarcerated, and it's a necessary platform for addressing mental health, substance abuse, and physical health issues. The former Secretary of HUD, Sean Donovan, said that housing is a powerful public health intervention that saves taxpayer dollars. On this page, we have information and links to just a handful of studies that talk about the benefits of housing and how it affects health and the costs associated with your health care. The first article talks about supportive housing in particular for people with a mental illness. It has quotes from Tom Dart, the Cook County Sheriff, who talks about the Cook County Jail being the largest state-run mental health facility in the United States. In 2013, they had 1,200 men in mental health dorms for an average stay of 87 days, which costs about $12,000 a person, and that money could be better spent and achieve better results if people were housed and served in their communities. The second study is a study of supportive housing in Illinois that was released in 2009 that found that there were cost savings in every system studied from pre-supportive housing entry to post-supportive housing entry. There was a 39% reduction in the total cost of services from pre to post-supportive housing with an overall savings of nearly $1 million. This was an average savings of about $5,000 a person over a 2-year time period, and this is a very low cost. We believe we're saving much more money, but those are the systems that we were able to get information from. The systems that were looked at within the study were Medicaid-funded services such as inpatient medical care, inpatient psychiatric care, nursing homes, and ambulance rides, uncompensated hospital services like inpatient medical care, inpatient psychiatric care, and emergency room visits, substance use treatment services like residential rehabilitation, halfway houses, recovery homes, and detoxification, and state mental hospital inpatient visits, state prison use, and county jail use. One of the key findings is that people once housed still have health care costs, but they're very inexpensive preventative health care costs rather than high-cost inpatient or emergency services. The third study is a local Chicago study called the Chicago Housing for Health Partnership, or CHIP. They decided to test the efficacy of Housing First treatment model to improve the health of chronically ill homeless individuals. They have evolved into a permanent citywide collaboration of housing, healthcare, and social service agencies. One of the key findings in the study is that for every 100 homeless adults offered the intervention of housing and services, the expected benefits include 49 fewer hospitalizations, 270 fewer hospital days, and 116 fewer emergency department visits. It suggests that if we house those 100 chronically homeless individuals, we'll save nearly $1 million in public funds per year. And the fourth study is a recent survey that was done by the John D. and Catherine T. MacArthur Foundation, looking at American families and where they have had to cut in order to maintain or obtain housing. And I found it very interesting because 14% of people reported that they had to cut back on their health care costs, and 12% of people said they had to cut back on the purchase of healthy foods in order to maintain their housing and the expenses associated with that. And we know that if people don't take care of their health and are able to eat healthily, then it makes it much more difficult to maintain your health as you move forward. These are just a handful of studies. There are thousands of studies that prove how closely integrated core health and housing are. The third objective within the Alliance Plan that we find housing aligned with is the idea of expanding the state's leadership role in promoting improvement. And Governor Quinn recognizes the importance of community integration and access to housing for all peoples across the state of Illinois. So in March of 2012, he hired one statewide housing coordinator and one regional housing coordinator for long-term care reform in order to work on the efforts to promote community integration and access to housing. In January of 2014, we ended up with 3 statewide housing coordinators for long-term care reform working out of the newly formed Governor's Office of Health Innovation and Transformation. Now I'm going to pass the slides over to my peer, Juanita Irizarry, who's going to talk to you a little bit about why it is important to have statewide housing coordinators at the Governor's Office.
Thank you very much, Lori. As Lori mentioned, Governor Quinn has been very interested in supporting community integration of people with disabilities. And what that means is that Illinois historically has tended to have a lot of folks with disabilities living in nursing homes and institutions because of the way our payment structures have worked largely. And now we are working to remake the system so that those people have the opportunity and the choice to live at home with family or live independently in their own apartment as they so choose. And that is something that Governor Quinn cares very much about, but it also comes out of a Supreme Court case called Olmstead and related class action lawsuits that have happened here in Illinois, which really call for all of us across the nation to support people with disabilities being able to live in the communities of their choice. The next slide talks about the Olmstead Supreme Court decision. It was a 1999 Supreme Court ruling, and it calls for the elimination of unnecessary segregation of people with disabilities. It calls for us to make sure that people with disabilities have the services that they need in order to live successfully in integrated settings. So instead of requiring that they live in institutions in order to get the services, we have to make the system work so that they can live in housing in the neighborhood of their choice and still be able to get the services that they qualify for and need in order to live successfully in the community. So in the state of Illinois, there are actually 3 Olmstead-based class action lawsuits that provide a context for this work. Filed in 2005, the Williams versus Quinn lawsuit alleged that Illinois was in violation of the Americans with Disabilities Act, or the ADA, which is actually celebrating the 25th anniversary this year of the Americans with Disabilities Act. And this particular lawsuit was really focused on folks with serious mental illness. Each lawsuit addresses a different class of folks, and the Williams, as we often refer to it, the Williams lawsuit has a class of 4,500 Illinois residents who have been diagnosed with serious mental illness, or SMI, and who were living in institutes of mental disease, which we often in Illinois refer to as IMDs. Olmstead, the Williams was settled here in Illinois in 2010, and again, not just because we had to settle the lawsuits, but because Governor Quinn really feels that these are the right things to do. We've put plans in place to comply with the lawsuit, requiring the transition of thousands of class members into these integrated community-based living settings that we're talking about. So that's an overview of Williams. Moving on, we'll talk about Liggis versus Hamas. Liggis was also filed in 2005, and this particular suit was focused on individuals with developmental disabilities. It's a class of about 6,000 people, and folks in this class reside in private state-funded intermediate care facilities for persons with developmental disabilities, or ICFDDs, as we often talk about them, of a certain size. So ICFDDs of 9 or more people, or they are at risk of being placed in those facilities. So that's the focus of Liggis. Liggis was settled in 2011, And it also calls for the transition of those folks who choose to move to be in community-based settings into settings where they have are in group homes of 4 people or less. 8 people or less, but we would prefer actually 4 people or less. Moving on, let me just say they don't have to go into group homes. They absolutely could also live in an apartment in the community if they so choose, and that's an important part of the work we're doing as well. Finally, the third Olmsted-based lawsuit is Colbert v. Quinn. The Colbert suit was filed in 2007, and it's an open class of somewhere between 14,000 and 16,000 folks. And these are folks living in nursing facilities in Cook County specifically. The other 2 are across the state. But Colbert is particularly focused on Cook County, people with disabilities with Medicaid insurance who are living in nursing homes. The Colbert lawsuit was settled in 2011 as well. And it requires that 1,100 class members be offered placement in permanent supportive housing by the end of the 30th month after the implementation plan is adopted. So it's important to understand these 3 lawsuits because they do they drive a lot of the work that we're doing in trying to remake the system to make sure people with disabilities get the housing but also the support services that need to follow them wherever they'd like to live. Now I'm going to pass it back to Lori for a little bit more discussion about some of the work that we do.
So just to follow up on what Juanita was saying about Governor Quinn's commitment to this work, it is great to see that the lawsuits were settled very quickly once Governor Quinn took office. Those lawsuits have been going on for some time, as you could see, and Governor Quinn made the choice to do the right thing for people and their communities and their families and settled those lawsuits so that we could begin the work of truly integrating folks into their communities. So we thank Governor Quinn for that choice. So we don't just do Olmsted-based lawsuits, things here at the Governor's Office of Health, Innovation, and Transformation Statewide Housing Coordinators. We spend a lot of our time looking at housing issues across all departments and divisions within those departments and trying to make things fit and work together so that we can make sure that people have access to safe, decent, affordable housing to improve their lives and their health. Some of the other issues that we work on are the Money Follows the Person program, which is a federal program that assists people with disabilities in moving out of nursing facilities across the state in order to move into their communities. And the way the money follows them is that the money that it costs in a nursing facility follows the person into the community to support them with the services that they need in the community to maintain integration and independence. We also work with the statewide referral network, and I believe that Sam will talk a little bit more about that from an IDA perspective. We have recently been awarded with our partners, the Illinois Housing Development Authority, a Section 811 rental subsidy demonstration program that is geared towards persons with that are Olmsted-related persons, so people with a disability that are residing in institutions in Illinois, and assist them in getting a rental subsidy that makes apartment affordable for them in the community, and ensuring then the other departments that are involved ensure that the services that they need to maintain in those apartments is provided. We work with public housing authorities. Brady and Juanita work closely in Cook County and the surrounding areas with those housing authorities, and I try to work with the rest of the folks throughout the state to try to get more resources. Public housing authorities have both project-based housing that is affordable and Section 8 rental assistance vouchers that people can access, and so we try to make sure that people around the state have better access to those resources. And we also are working on state-operated developmental center closures. We work closely with the transition team there that is working on assisting people in the 6 state-operated developmental centers around the state for people with intellectual and developmental disabilities to move into the community if they so choose. And a variety of other pieces, both looking at people experiencing homelessness, people involved in the criminal justice system, people that are aging out of the child welfare system, and a variety of others that are not listed on this slide here. So just to tell you a little bit more about what each one of us as statewide housing coordinators is tasked with or targeted to do. I, again, am Lori Baker. I am concentrated in Springfield, so I'm kind of your central Illinois, southern Illinois, downstate connection to housing resources and policy. My focuses are the Ligas v. Hamos class action lawsuit in consent decree and state-operated developmental center closures. I work closely with the Money Follows the Person initiative and their expansion efforts in other counties outside of Cook. I work closely with public housing authorities that are outside Chicago and the Cook County region. And I have been working with the lead referral agents that are involved in the statewide referral network outside of Cook County to support them in their efforts.
Hello, I'm Brady Harden. I'm the regional housing coordinator that was mentioned earlier that was hired back in March of 2012. And we made a decision just prior to Lori and Juanita coming on board to create the office that now houses 3 statewide housing coordinators. We each have overlapping responsibilities, but we have key areas of focus. My area of focus is primarily dedicated to coordinating the housing resources for Williams and Colbert consent decree members. Each of the consent decree implementation programs, stable housing is a key component of each of those consent decrees. Now more about Williams. Williams versus Quinn. These services are coordinated by the Illinois Department of Human Services Division of Mental Health. The role that we have is to help to coordinate the housing opportunities to persons who are living in IMDs. This project is supported by 17 community mental health centers who provide a full array of support, including transition services. Through outreach, we meet regularly with developers and housing authorities, and we share these resources with staff of the Division of Mental Health as well as state contractors. Our overall goal is to meet the needs specific to each class member. One of the things we've done in this effort is that we just recently created, and working closely with the Division of Mental Health and Thresholds, our very first cluster housing model, which is a pilot project created to support persons with very complex medical needs. Thresholds has identified 20 Williams class members who with support can now live independently. Residents receive round-the-clock support from Threshold staff, including the nurses on duty, and maintains an office on the property to respond immediately to the needs of cluster housing residents. Of course, the Colbert versus Quinn consent decree has been a great challenge for us. The information of this project was initially developed and coordinated by the Illinois Department of Health Care and Family Services. Since January 2004, the Illinois Department on Aging became the implementing agency of that project. This project is required to assist residents with disabilities living in skilled nursing facilities in Cook County. The care service is provided by Aetna Better Health Care and Illini Care Health Plan, and they provide interdisciplinary teams to manage the processes required by the consent decree. The housing search and placement is coordinated by 3 contractors. They are Featherfist, Access Living, and Harden Human Care. To date, nearly 300 persons have been transitioned into the community over the past 18 months. One of my other responsibilities is that of lead referral agent for Cook County, and in that aspect we work very closely with IDA. This project links persons with disabilities and persons who are homeless to IDA tax credit properties in Cook County as part of the statewide referral network, which Sam will explain more in detail. These units are linked to IDA low-income housing tax credit targeting program to provide community integrated permanent supportive housing opportunities. Typically what happens is developers set aside 10 to 20% of low-income housing tax credit units for persons with disabilities or persons who are homeless with rents at 30% of the area median income. As Lori said, we all work closely with public housing authorities here in Chicago. Our work is closely centered around the coordination of housing efforts with both the Chicago Housing Authority and Housing Authority of Cook County, in ensuring that persons with disabilities have access to public housing. The Housing Authority of Cook County has established a preference for individuals with disabilities currently transitioning from institutional settings into community-based settings, and CHA has confirmed its commitment as part of its application process with IDA to provide up to 400 housing to 400 Olmsted class members. So that is the work that I'm principally involved in. But as with Lori and Juanita, we're all involved in the coordination of housing efforts throughout the state.
So this is Juanita again, and I'll just briefly go over the pieces that fall under my purview. I work across various departments and agencies at the state, chairing an interagency panel that is working on the implementation of the Section 811 award, which Lori mentioned, $11.9 million that are coming in from HUD. And you'll hear a little bit more about that from Sam in a moment. An important platform for making that program work is the statewide referral network, which the Illinois Housing Development Authority established, and we help to make function. And an important part of that is the www.ilhousingsearch.org tool. It's a housing locator website which is available to the public to help connect people with housing. And our specific use of it is to help people with disabilities and people who are experiencing homelessness make connections, particularly with folks all over the state who have in their private market units as well as in publicly funded units low-income housing available for those folks. And so I help to make sure that we have the interagency collaboration working to make all of these work and to do training to various internal and external partners so that we can make all of those programs work. And as mentioned, I also work with public housing authorities here in the city and the county to make sure that those programs that we have made commitments with and they've committed with us, that they're actually functioning and operational. So at this time, now that you've heard about all of those tools and resources, I'm just going to go ahead and pass it over to Sam Mordka, who is a Senior Development Officer at the Illinois Housing Development Authority, or IDA, and a key partner with us in all of this work. Sam, take it away.
Hi. As mentioned, my name is Sam Mordka. I'm with the Illinois Housing Development Authority. Our Executive Director, Mary Kinney, is very tuned in to the long-term care rebalancing initiative, as is the Governor himself. And I don't think enough has been said about the Governor's dedication to this and his knowledge not just of the healthcare side but also of the housing side. So I want to mention that. First, we're going to talk a little bit about the low-income housing tax credit, and I'll try not to be too technical because it is a housing program. The low-income housing tax credit was established in 1986 as part of tax reform legislation. And what it does is it creates a public-private partnership to develop affordable housing outside of the traditional HUD model. This is a program run by the United States Treasury, and it allocates these low-income housing tax credits to state housing finance agencies and then we allocate them further through a qualified allocation process to developers. Those tax credits are sold into the secondary market, and that creates the capital to build housing affordable to persons at certain levels. One of the important things to understand is that housing created under this program is not like HUD public housing or Section 8. Residents don't automatically just get to pay 30% of the income with the rest coming from the federal government. How this makes housing affordable is with this capital, the developers agree to keep their units affordable to persons at certain income levels. So typically how the program's been used is it's been used to keep units affordable to persons at 60% of the area median income. Through our qualified allocation program, IDA has taken the further step to ask developers to make units, a certain percentage of their units, as alluded to before, affordable to persons at 30% of the area median income. In addition to this, we formed a partnership with originally DHS and now with the Governor's Office, DHS, HFS, and the Department on Aging to take referrals into those units as part of the statewide referral network. So a developer applies for these tax credits, they're allocated the tax credits, the building gets built, and let's say that's 100 units and they have 10 statewide referral network units. So how those units must be filled, and the developer must comply with this and we monitor it, is that a service provider, whether it's a service provider for persons with disabilities, whether it's a service provider for homeless community, they make, or any, obviously all of the transition coordinators under the various lawsuits should be participating in this and have been educated about it. They make their referrals through the statewide housing coordinators and the local referral agencies, which are 4 positions scattered throughout the state. Well, 5 including Brady, but he wears so many hats and has so many responsibilities that this is just part of his job. They make the referrals to the lead referral agencies, which refer them on into the units, to the property managers. Now, once the referral is made, those clients of yours, and I assume we mostly have service providers on the phone, those clients of yours have the exact same rights and responsibilities as anybody else who knocks on the door looking to lease an apartment. Once they are housed, if they are housed, they have the exact same type of lease and the exact same rights and responsibilities under that lease as anyone else living in the building. And these are truly integrated units. Since inception of this program, IDA has created in excess of 1,200 units of fully integrated permanent supportive housing. One of the reasons this is such an important tool for us is because on a federal level, excuse me, the Department of Housing and Urban Development and the Federal Department on Justice have really been looking at the 100% supportive housing model of housing persons with disabilities. And while we don't have a definitive answer yet, it seems that they believe that that type of housing, 100% supportive housing with services on site, might also be a violation of Olmstead. Now, IDA's position on this is that what Olmstead truly speaks to is choice in housing for consumers. And IDA believes that just as there is a wide variety of persons with disabilities and homeless persons, there is a wide variety of housing that they might choose, and that certain persons with disabilities might choose, given all the options, and they must be given all the options to live in 100% supportive housing. So we like to make sure that we create housing that is varied and is of all levels for persons with disabilities so that they have true choice and opportunity in their housing. That's the 30,000-foot overview of the tax credit program and the SRN. My last word on the SRN is some of you might say, well, why can't I refer my client directly to the housing Why do I have to go through the lead referral agency? And there's a couple of reasons for that. The first reason is, based on the name of your organization, the property manager might figure out the nature of the disability of your client. Property managers cannot legally ask about disability. It's a protected class, and it's illegal for them to ask. So why would we tell them up front? If your client wants to self-identify as a person with disability, have at. More power to them. But we don't need to tell them up front so that they're prejudged. The example I like to give, not to call out thresholds, is pretty much all the landlords in Chicago know that if they get somebody from thresholds, they're serving somebody with mental illness, and the on-site property manager doesn't need to know that information unless the person self-identifies. The other thing it does is, because we are a finance agency and the developers and property managers are our clients, is it gives the property manager a single point of contact of who to contact if the tenant is having an issue with their lease. If they are not in compliance with their lease before they go down the road of eviction or non-renewal of lease, which are expensive options and they don't like to do, everybody wants to keep people housed, they can call the lead referral agent and say, we need some services to keep this person stably housed. The lead referral agent then reaches back out to the original referral agency and asks the referral agency to offer that client services. Services are never a condition of tenancy. No clients can ever be forced to accept services. Okay, so I'm off my soapbox on that. Affordable Housing Trust Fund. Before we talk about that, I want to talk about something that the governor did in 2009 that is really wonderful, and I'm moving quickly on this. The governor, as part of the Build Illinois bonds, for the first time ever gave capital to IDA, $130 million to do housing programs. In the original legislation, only $30 million of it had to be for supportive housing. IDA took the step to use $75 million of the $130 million to create permanent, affordable, supportive housing units. The Affordable Housing Trust Fund, thank you for all of you who are home buyers. This is funded by a transfer tax on real estate. 50% of the transfer tax on real estate goes into the Affordable Housing Trust Fund. It is an immensely important resource in getting supportive housing done, because when we talk about low-income housing tax credits, that doesn't complete the development, and having those extra funds to put into rental development to get the housing done is critical. Very briefly, I'll touch on Section 811. We do not have a signed cooperative agreement with HUD. We hope to have that by the end of the month so we can begin rolling out this rental assistance. When we spoke earlier about the 30% AMI rents for the statewide referral network, let me just point out that in the city of Chicago and in the Cook County area, a 30% AMI rent translates into $400, $420 a month, not affordable to somebody on Social Security income, on baseline SSI. It's a mismatch. We needed to fix it. The federal government recognized we needed to fix it. We will now be able to lay this rental assistance over those units so that the people referred into those units will only pay 30% of their income in rent. The rest of it will be paid by the federal government, and they will remain successfully housed in those units. Those units will be filled through the statewide referral network, and what we have told the federal government is that we will use those units for the 3 Olmstead classes, participants in Money Follows the Persons, and persons affected by the closures of the state-operated developmental centers. Last word, then I'm done. What we have to remember is that unlike these lawsuits, which hopefully we will have completed our settlement agreements within 5-7 years, I don't know the timeline on that, these units will be affordable for a minimum of the next 30 years. These are something you will have in your toolkit for a minimum of the next 30 years. We will have these regulated as permanent supportive housing for the next 30 years. Don't forget about these units once these lawsuits are settled. We will continue to have these units available to ensure that persons with disabilities and persons experiencing homelessness have safe, decent, affordable housing integrated into the larger community. Thank you for your time.
Thank you very much, Sam, and to the presenters today. We're going to move into the question and answer session. Just a couple of notes before we start. Please make sure to type your questions into the chat box of the webinar presentation. If you have your hand raised right now, please make sure to ask your question via chat. We also will make the slides available to everyone along with the recorded presentation. So if you were asking about a copy of the slides or having the presentation emailed, we will absolutely be doing that after the presentation is over. You can access the slides and the archived recording through www.healthcarereform.illinois.gov. I'm sorry. Yes, that's correct. If you have any questions about the session today, the presentation, or anything moving further with GOHIT, you can email the email address on your screen. It's gov.gohit@illinois.gov. So we're going to get started with a few questions that we have here. The first question is, can CMHCs access Section 11 funds to provide housing and services to people?
I can go ahead and answer that. If the Community Mental Health Center is working on one of the consent decrees or working with Money Follows the Person, yes, they can refer people into the 811 units. But what I want you to remember is outside of the 811 units, we also have a number of statewide referral network units that if your client is not a member of one of the lawsuit classes or participating in MFP, one of those units might be appropriate for them. But the 811 units right now are specifically, and we told HUD and federal CMS that this was the case, specifically for class members, persons participating in Money Follows the Person, and persons affected by the SODC closures.
And so community mental health centers can refer people into those units that are project-based units, but they can't develop housing and expect to get Section 811 rental subsidy to put into that housing unless they develop low-income housing tax credit and get approved by HUD or by IDA. But those project-based rental assistance Section 811 units will be in buildings that already exist or are coming online currently, and that rental subsidy will not be tenant-based and won't be able to float with the tenant. It'll be to the unit, so they can refer people into the unit, but they can't access the rental subsidy for their own properties.
Great, thank you. Taking a step back, but along the lines of Section 811, can we explain at a basic high level what Section 811 means?
Sure. The original Section 811 program, which I believe came out of the Cranston-Gonzalez Act, was a program where not-for-profit developers could apply directly to HUD for both capital dollars to build a building and operating assistance to run a building, specifically for extremely low-income persons with disabilities. The issue with this is that those developments may or may not be a violation of Olmstead because they were 100% disability. In 2010, the Frank Graham Act changed this and allowed housing finance agencies to apply to HUD for just the rental assistance portion, no capital, and then be able to allocate the rental assistance units to developments that the housing finance agency financed either through the low-income housing tax credit program, the home investment partnership program, or state housing trust fund units. We cannot exceed 25% of the units in any one project with 811 subsidies. So if you have a 100-unit building, we will not go above 25 units in it. And more likely, as a policy, we'd like to keep it even more integrated and stay around the 10 to 15% mark because we think that that's a little bit more integrated than the 25 that HUD and CMS allow us to go to.
Great, thank you. We have a question here about signing up for the GOHIT work groups, and I'll just go ahead and answer this. If you are interested in signing up for a work group that Michael described, please send an email to gov.gohit@illinois.gov. Give us your contact information and let us know what work group you are interested in. Another question we have here is, where can I learn more about the cluster housing model project?
If you provide us with your email address, I'll give you my email address. I'll be happy to give you a link to information about it. My email address is Brady, that's B-R-A-D-Y, .Harden, H-A-R-D-E-N, @illinois.gov, and I'll be happy to share a little tidbit about it.
Great, thank you. Another question is, what is in the 1115 waiver to help provide supports or funding for supportive housing?
So there are a couple of different ideas expressed within the 1115 waiver that we hope to get approved that would assist with supportive housing development and services. One of the ideas is the idea of an incentive-based fund that managed care organizations or community mental health centers might receive incentive-based payments if they meet their goals of keeping people housed and healthier, and that money could then perhaps be accessed by people in the community that want to create supportive housing. We will be working on the ideas and how to implement that in the work groups, especially the supports and services work groups, or if you're interested in giving feedback on how to perhaps use the incentive funds, you need to get involved with the long-term services and supports work group, and you do that by going to gov.gohit@illinois.gov. One of the other things that we hope to get included within the 1115 waiver is the idea of Medicaid-approved services that help support people in supportive housing that are non-medical. So the supports that are involved with intensive case management, transportation, and a variety of services. So we'll be also working on that as we negotiate with federal CMS through the 1115 waiver process, and we'll be working on that within work groups in the supports and services work group.
Let me add just one more comment on that. I think it's important to underscore two points. One, this is a waiver application, which means this is how we're structuring our request to federal Centers for Medicare and Medicaid Services. It doesn't mean that they're going to approve what we're requesting, and a lot of negotiations will be underway shortly, or are underway now, in fact, to help secure the funding that we're seeking, but it's not in the bank yet. The other point to remember as you're considering the housing and health connection under Medicaid is that Medicaid is not, it's run by federal CMS under HHS. It's not HUD, the Housing and Urban Development Department. And the federal government, like all government agencies, tries very hard to keep their portfolios independent of each other. But as Sam pointed out in the thrust of this discussion, is that there's been huge progress made by HUD and HHS working together at the federal level, and we're trying to build on that here and utilize perhaps some room in that housing and health intersection to secure some Medicaid funding that can help us with housing. But we should be clear that the Medicaid program does not per se fund housing, so we have to be more clever and more sophisticated in our application of funding under Medicaid, so that it ties directly to the health outcomes of the people that are being served under Medicaid, and not that it's money to support capital or rental costs of housing, which is specifically not covered under Title 19 for the Medicaid program.
It's health insurance, not service or housing insurance.
Thank you. Our next question is, how would you see hospital discharge planners interfacing with these services for qualifying individuals?
That is a really good question. I think that hospital discharge planners will want to interface with these services, and we haven't quite figured out in our new healthcare models how that's going to happen, because most supportive housing and most affordable housing has very long waiting lists, and the people who are being discharged from the hospital don't have a year to wait to get a affordable supportive housing unit. So that is part of what we need to be working on through work groups and policy and planning in order to ensure that there are ways to access the resource for people that are very vulnerable and who, when discharged from the hospital, might be discharged into homelessness, which will then exacerbate the issue that they were in the hospital with in the first place and cause a reoccurrence of them being admitted into the hospital. But we don't have a good answer yet, but are hoping to work towards ways to put together resources in order to streamline that process.
And that is central to the 1115 waiver, because what we've proposed is an incentive payment to managed care entities that are people who are coordinating the care that would reward them if they were able to find housing. So it does put the burden on them to find the housing to prevent hospital readmissions and all the other bad things that happen if people do not have adequate housing. So we recognize that, but that's really the essence of what our waiver request is try to link that incentive payment to managed care so that they are then incentivized, and discharge planners working in the hospitals that work for them are incentivized to find housing. The last question.
Great, thank you. And so our last question for today is there a requirement under the Low-Income Housing Tax Credit Program of not mixing seniors and persons with disabilities, or under the 811 program?
That's an excellent question. Under the Low-Income Housing Tax Credit Program, there's nothing specifically that prohibits seniors mixing with persons with disabilities. That said, a developer can elect to create a low-income housing tax credit development that is restricted to seniors. They can restrict at age 55 or they can restrict at age 62. So no one under those ages could live in those buildings, but that doesn't mean that somebody 55 or over, 62 and over with a disability couldn't live in the building. And there's nothing to say that in a non-age restricted low-income housing tax credit unit, a senior couldn't move into that unit. As a matter of fact, there's many low-income housing tax credit units that are not age restricted that have seniors living in them. Section 811 is a little bit different. Section 811 was specifically created to serve non-elderly persons with disabilities. So a participant, somebody referred into a Section 811 unit, must be under the age of 62 at the time of referral. When they're housed, they must be under the age of 62. They have to be between the ages of 18 and 62. That said, if you refer somebody who's 60 into an 811 unit, 2 years down the road, they do not lose their unit because they were qualified for it when they moved in, and they will not be kicked out of their unit for aging out. They will be allowed to age in place. So I hope that answers the question. I did my best.
Thank you, Sam. That was our last couple of questions. Just a reminder, we will be sending around the slide deck and the recorded presentation after the webinar is over, and I will turn this over to Mike for a few last thoughts.
Well, great. Well, thank you, Jennifer, and to Juanita, Lori, and Brady. I want to thank you as well. Coming into this new position and creating it is a challenge, but as I think we can see from the questions and from your own careers in supporting housing, it's essential, and I'm very glad that the Governor's Office has been able to accommodate this need. And then to Sam Mortka, representing the Illinois Housing Development Authority, as Sam expressed earlier, I mean, this reflects really an unprecedented level of cooperation and coordination between and among the state agencies and IDA, Housing Development Authority, and with the Governor's Office. And this is a tribute to our ability to work together at the in the weeds here, in the Governor's commitment to make sure that health levels are improved, care is affordable, and that our health delivery system works, and we know that housing is entirely all important to make those that triple aim succeed. So I thank all of you for your participation today. I thank those of you on the webinar, and we will look forward to the next webinar in July.
Thanks, everyone.